And then when it comes up from the bottom half of the body, the inferior vena cava, they both come into the right atrium. Next they come through, this was the tricuspid valve, so this opens up and then the blood comes into here, the right ventricle. Okay, and then this squeezes and it goes out to the lungs, goes out the left lung here and the right lung here, and there's supposed to be a valve here, which yours isn't. And so what happens is that if there's no valve here, the blood gets squeezed and then kind of goes back and forth, and what ends up happening is this gets really dilated. And even thin sometimes, so it has a hard time squeezing. When the heart gets big, the reason it has a difficult time squeezing is if you think about it like this, if you have your arms like this, you can squeeze really hard. If you have them like this, you can't squeeze very hard. And that's kind of what happens here. Okay? So the function's worse, and some of it is just the fact is that it's inefficient, that the blood just is going back and forth. Okay? The other thing happens when this dilates, this part dilates as well. So if you look at this part of your heart is really big too. And so you have the vena cava coming in, and this is really dilated like this. And so what happens when these structures dilate, this one and this one, they're more often have dysrhythmias or funny rhythms. Okay. And so the thing that we need to fix in your heart is, number one, is replace the valve here, with the pulmonary valve, and what we'll replace it with is a prosthetic or it's a porcine or pig valve.
Yeah, they tell me about that.
Okay. The reason that's good, I mean, that's what we do anyways. The thing that's nice about this is that when you need this replaced again, because that won't last you forever. They don't last forever, unfortunately. Dr. Abelhausen will be able to put just via catheterization rather than another surgery. So that's a big advantage. The other thing we're going to do is that we're going to actually freeze little lines into your heart, like here, here, and here. And what that is because the pacemaker of your heart runs here, and then it has a little nerve that runs along this area down here, okay? And then it actually kind of comes through here to the septum. But because this is all stretched, there's impulses that are coming from many different places. So what we do is we kind of block a tunnel for this one nerve or this conduction to go in the right spot, and so it'll make the likelihood that you have these dysrhythmias, that they would become permanent. Because sometimes these little dysrhythmias that you can have, they're just transient now. They happen only so often, but as you get older, they can become more permanent, and that's a big problem. So we'll just make sure that there's that we just have one channel for those nerves, and that's called a Mays procedure. And that's just like I said, it's cryoablation. What we do is we make these little lesions in the heart, meaning that there's the nerve conduction can't go past. So these abnormal impulses don't go into where it's supposed to.
All right, so you guys are like, there's gonna be like the new valve here, right?
In the middle.
And you guys are gonna put like a little wall.
Well, it's gonna be actually what it's gonna be is actually you freeze the tissue. Actually, you put a little, and when you freeze it, the nerve impulses that we don't want to go through can't get through that. It becomes unfrozen, obviously, but it's damaged actually, but it won't allow this other conduction, the conduction of the impulses we don't want to get into that tunnel. Does that make sense?
Okay. Yeah.
And so, because when things stretch, especially like there are other places here that can have impulses that cause your heart to go faster, and if we block those, and the normal one goes through, then your heart will beat normally. But if we don't block these, what can happen is as you age, and if this distends anymore, you can have those dysrhythmias you have can become permanent. So that we're just trying to guard against that. And the risk of doing this on the right side, what we're going to do are very low. Very low.
On the right side? That's going to be on the right side?
We're going to be, the right side. All this is on the right side of the heart.
Okay.
So the risks of that procedure, I can't say they're zero, but they're very low. And the possibility of keeping you out of those dysrhythmias is a really significant thing. Because if you go into these dysrhythmias and they continue and they don't stop, you have to go on blood thinners and everything else. So it's a something I think that will decrease your risk of having problems over time. That's why we do it.
All right.
Okay. So we'll go through an insane incision on your chest. We'll have to put you on the heart and lung machine for a short period of time while we're doing this. You'll probably be on the machine for about 35, 40 minutes. Well, we'll replace that valve and then do this maze procedure. Okay? Usually people your age that have this done, they're in the hospital about 3 or 4 days. Is all. Can be a little bit longer, can even be shorter sometimes, but they'll come out with the incision and the little tubes that drain the fluid and air.
And they're not going to open over here no more, huh? Not over here, only over here.
Just in front.
Only in front?
Only
Okay.
in front. Only in front. And
how long does that procedure take?
the procedure takes probably about 3 hours.
3 hours.
Yeah, about 3 hours. And like I said, you'll be in the ICU when you get back from the operating room. The breathing tube, they'll probably try to take the breathing tube out when you're downstairs, but if not, it'll come out when you're just after you've got back upstairs in your room. And you'll be drinking fluids and sitting in a chair probably the same day of surgery. And then they'll hopefully get the tubes out the next day, walking around, and then as soon as you're eating and your pain's controlled, you'll be able to go home. Okay? And I think you'll feel a lot better once this gets done too.
And once this is done, does it take a while to fully heal? Like doing physical activities?
Absolutely. Well, you have to protect the sternum. First of all, it's like a broken bone. It takes about 6 weeks to heal.
Okay.
So they'll tell you exactly what to do and what to. We don't like you to drive for at least 3-4 weeks after that. The biggest thing is not using your arms to push up on anything, and essentially rolling over and sitting up, and not using your arms, because when you use these arms, it pulls this part.
Okay.
And so that's the only thing. And not lifting anything heavier than 25 pounds for the 6 weeks.
Yeah.
For 6 weeks?
Yeah.
Okay.
Until it's all healed up.
And so you were telling me about this risk, like what, like infection?
I'll tell you all the risks. The biggest risk of this surgery is not doing the surgery.
Yeah.
Because you have symptoms, and I think you're at a risk for having these dysrhythmias become permanent. So I think you're the biggest risk not doing it. Anytime we make an incision anywhere in the body, pain, bleeding, and infection, there's about a 25% chance you'll get a blood transfusion at the time or after surgery. So it's low. It's 75% chance that you will not. It's someone your size getting this surgery. It's very infrequent, unless you come in with a blood count that's low already, which happens sometimes.
Okay.
Infection rate is about 1%, and that's a serious infection where we have to do another operation to clean things up. So it doesn't happen very often, but it is possible. The machine I talked about. Now, the machine allows us to do the operation, number one, and it protects all the organs in your body while we have your heart and lungs stop for a short period of time. Those same organs can be injured. The ones we worry about most are the brain and the kidney. There's about a 2% risk of something that would be permanent. So it's very low, but it's not zero. Okay? The specific to this operation, we already talked about a few. Reoperation or needing another valve.
Okay.
Even though we know where to put these lesions, there's a risk that we could injure the nerves of the heart, and you'd have to have a permanent pacemaker. The likelihood of that's low. It's less than 5%, so very low, but it's not zero. God forbid that would happen. It wouldn't affect how you lived or how long you lived. It would just you'd have to get battery replacements, essentially. Yeah.
Right.
So I don't expect anything like that to happen, but it can. But it can. The risk of someone having this type of surgery that doesn't live through the surgery is very low. It's about 1%, so very low, but not zero. One of the biggest risks is going in through the sternum again, because there's scar tissue that forms there, and then you can injure the lung or the heart. And there can be significant and even life-threatening bleeding. It doesn't happen very often. And we're going to have you get a CT scan of your chest so we know exactly where everything is.
Okay.
Even with that, sometimes the back of the heart is, because it's dilated so much, it's kind of stuck to the sternum. So sometimes we have to go on the bypass machine through the vessels in your groin. And so we make just a small incision there, and we go on the bypass. What happens then is allows the heart to empty, and it's much safer to enter. So I'll be able to tell you that more accurately once I see the CT scan.